I'm very happy to now be standing in front of you with my PowerPoint pulled up and have the opportunity to talk to you a little bit about gift law, organ donation, why gift law matters, and how this is all put together into a system to really maximize life-saving donation and transplantation. So with that, hopefully, and a little magic, this is going to go to the next slide. Yes. Okay. So I know it's really early in the morning for law class, but we're going to start with some of the basics because really the structure for how we conduct organ donation in the US begins with this basic legal framework. And it really does inform how we do so much of our work. And it's different than what healthcare providers are accustomed to. So we work with the Uniform Anatomical Gift Act. This is the primary legal authority for organ and tissue donation. It's a uniform act, which means that it's model legislation. So it has to be enacted state by state by state, but the idea behind it is that it's consistent across every state, even though it's not a federal law. And it's not a new law. It was actually put in place pretty quickly when organ donation and transplantation was first developed in 1968. And it's been revised a bunch of times since then to try and keep up with some of the changes that have happened in the field. So I'm going to start with a question for you all, which is pretty foundational. The law requires informed consent for deceased organ donation, ? True or false? So we can have a show of hands for true. And a show of hands for false. And a show of hands for like, I have no idea and that's why I'm in this lecture. Okay, fair, right? So it's actually false. And I think people find that really surprising. And so the Uniform Anatomical Gift Act is not based on informed consent principles. And this is in part why we use the term authorization in the donation community. And you hear that a lot. Authorization isn't really different than consent. Both are to discuss legal permission, but we use the term authorization to try and distinguish it from the concept of informed consent, which the medical community is really super familiar with. But informed consent is a specific legal principle that applies to healthcare treatment decisions. And really, when we talk about informed consent, we're talking about the facilitated understanding of risks and benefits to the patient of a particular treatment alternative that they're going to be making. And from a legal perspective, that comes out of the doctor-patient fiduciary relationship. And that's the whole legal concept of informed consent. And it really doesn't apply in deceased organ donation because there are neither risks nor benefits to the deceased donor. They will be deceased at the time that the gift is made. And they can make this decision about organ donation completely outside of the fiduciary relationship of the doctor-patient relationship, right? In fact, actually way outside. Like, where do they usually make that decision? At the RMV when they're getting their license. So it is completely separate from informed consent. And the law recognizes that by not using informed consent as the legal framework under the Uniform Anatomical Gift Act. So if informed consent is not being used as the primary legal principle for organ donation, then what is the primary legal principle that's being used is the question. Any guesses? It's pretty early. Well, if it's not informed consent, what is the legal principle that might be behind organ donation and tissue donation?
What's
Authorization, but there's actually a legal term of art, and that is gift. Ta-da, gift. And so gift under the law, whether it's an anatomical gift it's a gift to the university, it's a gift to the hospital, it's a gift to a family member, like through a will, is defined under the law as a voluntary and legally binding uncompensated transfer. And this is really important to organ donation, that there be all of those components, that it be voluntary, that it be legally binding, right? We don't want this situation where somebody wants it back. And this is actually a real case, of course, as a living donor, but this was a real case in New York. She didn't get her kidney back. We do want to make sure that the law recognizes that that transfer is legally binding and that it's uncompensated, that we have a system of organ donation that does not involve paying for organs. So gift law, which is its own principle in the law, is underlying the framework for organ and tissue donation in the US, and this is how gift is defined. So I already talked a little bit about the fact that there's these three pieces here that are principles behind gift law that are really important to our system: the legally binding transfer, the prohibition on valuable consideration being a fancy legal word of saying exchange of money, and that it's really founded on the concept of altruism and autonomy, that individuals have the right to make this gift, and that it's based on altruism and that voluntariness. And that's a core piece ethically of our system for organ donation. The other piece in the law that's core is that the anatomical gift is conditional. It's conditional on death. So you make the gift in advance, just like a will, but the transfer of that gift, the organs, will happen upon death. And it's also conditional on clinical suitability. So sometimes I get that question too, like, so is there a legal requirement to recover and transfer gifted organs, even if they're not suitable for transplant? And the answer, as you likely all know, is no. It has to be conditioned on clinical suitability. And the law recognizes this by basically saying that there needs to be permission for the what, so what's being gifted, organs, tissues, eyes, corneas, and also permission for the why. What's the use that the gift is going to be, the purpose for which the gift is going to be used? So transplantation being primary, research and education also being possible, but it's actually defined in the statute. So these are the three purposes for which anatomical gifts can be made. So it can't be just like for any reason, right? It can't be this. There's some really weird cartoons out there related to organ donation, but I have found most of them. If you guys find any good ones, send them my way. But it is really very limited, and it's prioritized so that if an individual doesn't make a specification, which is the case if you're going to the donor registry, you're not giving specific permission for individual things, for individual whats or individual whys, then transplantation is going to be prioritized. And it says that right in the statute. So the other thing that the Uniform Anatomical Gift Act does is set up this idea of first-person authorization, which is a somewhat awkward way to say that adults have the right to make their own donation decision and that it's legally binding upon their death. This is not a new concept in the Uniform Anatomical Gift Act. In fact, it was put in the statute in 1968, and it very much follows the same concepts that we see in estate law, that adults have the right to kind of dispose of all of their property. It comes from property rights as they see fit. And so under the Uniform Anatomical Gift Act, a gift can be made by an adult prior to death, and that's the primary way that organ and tissue donation can be authorized, by an individual themselves before they die, or by a surrogate decision maker at death if the adult doesn't make a decision themselves. So there's two ways for authorization to occur. The UAGA also sets up ways that this gift has to be documented. And so, lawyers like to have all these specific rules about documentation. There's something called the document of gift that satisfies that first legal element of gift law. Who remembers what the first legal element was? Did I even go over it? Not sure I did. Okay, so you know what? I'm not sure I put this in here. I don't think I did. So you have to have intent, and then it has to be transferred, and then it has to be accepted. So the document shows the intent to make the gift, and then the gift will be transferred, and then it is accepted. So there are 3 components there, and it has to be signed. So another question for you all. Which of the following are legally recognized ways to make an anatomical gift? Signing up for the donor registry, a written statement in a will, a verbal statement to a family member that you want to be a donor, all of the above, A and B, but not C. Votes for A, B, C. So it's really about D or E. D and E. Okay. And again, maybe some that are like, this is why I'm here. So it's actually E. And so think about it this way. The law doesn't like verbal statements. It's just like your will. You have to have it in writing in some way. And writing can be electronic, and so that can be through the donor registry, at the RMV. It certainly can be a written statement in a will. Wills are not very useful in these moments because if someone shows up to the hospital with a will, you got to wonder what's going on there, right? That's a little odd. I have seen that in my years in this field, but it's very unusual. Verbal statements aren't going to cut it, and they're not going to cut it, either way. You really have to have this decision be documented in some way. Okay. The ethical basis for all of this is relatively simple. It's based on ideas and concepts of self-determination, that adult individuals should be able to make this decision for themselves. It's consistent with other principles, with ethical principles behind other advanced directives, and certainly also consistent with estate law, as I already mentioned. So it sort of straddles both fields of property law and healthcare, recognizing the fact that deceased organ donation is going to occur after an individual dies, but that it's also tied up at the very end of life when there are healthcare decisions happening right beforehand. And so I think, all of this is really an autonomy principle that is central to how the Uniform Anatomical Gift Act has set up the framework for organ and tissue donation. And so with this kind of opt-in system that we have in the US, we have driven people to make that decision primarily by registering as donors through the RMV when they get their license and when they renew their license. And so I'm wondering how many people in the US are registered as donors. What do you think? Where are we at? Show of hands for 5 million, 25 million, 75 million, 170 million. So you might be floored to know that actually at the end of 2023, there were about 170 million registered donors in the US, which is about 55% of the adult population, which is amazing. So our opt-in system through this gift law framework has been very successful in having individuals make this decision to opt in and be donors. And, there's two ways to do this, or there's actually many ways to do this. We've already mentioned the license. You can also do this through your iPhone and through the health app. It's about 30 seconds. So this is where I usually get the question of, but this isn't an informed consent process. Or I'll get a comment like, I went to the RMV and it was not an informed consent process, right? And so now you know the answer to that, which is it's not an informed consent process. And it's not designed to be an informed consent process, and it doesn't need to be an informed consent process. It's authorizing a gift. It's opting in to the donor registry. And adult individuals have the ability and right to make that decision or to decide not to make that decision. But that's why the registry works as a legal matter, because it is wrapped in a gift law framework, which is really different than the framework you're used to working within in healthcare decisions. Our system design is really a good one because it provides two pathways to a yes. And because sometimes I also get the question of like, well, should we consider an opt-out system and, presumed consent? And one of the things I'd like to point out is that, so we have this donor registry with 170 million registered donors, but we also have this middle pathway where there's been no decision made. And with the no decision made, if there's a potential donor, and notice that's a very small percent of the total inpatient deaths. I'm going to get back to that point in a little bit later. But if there is a potential donor and no decision made, then we're approaching surrogate decision makers and asking them for authorization. And they can say yes, or they can decline, but it gives two pathways to actual donation. And that system design generates actually substantial numbers of organ donors. In fact, we've had almost double the number of deceased organ donors over the past decade in the US. The growth has been really substantial. And it mirrors what you saw in the donor registry numbers as well. 98% increase over the past 10 years. This is overall US data. I do like to take a minute and just say that sometimes I hear, well, that increase is because of the opioid epidemic. And it's important to recognize that the opioid epidemic, sadly, has shown up in this data. And you can see the blue line here, that there's been an increase in the number of donors that have died of a drug overdose, but that actually the increase overall has substantially not been driven by the opioid epidemic. That 77% of the increase has been from donors that have died of other causes. So while the numbers have, in percent of donors that died of overdose have increased steadily from 2013 to 2023, it's still a very small percent of the overall picture in the US. And I think, especially in an area, I come from Boston, the Northeast has been hit very hard with the opioid epidemic. There's no family that has not been touched by it, including mine. And it's really important to recognize that nobody wants to see two public health crises, collide like this, but that it is unfair to the donating public to say that the opioid epidemic has driven this growth, when in fact it's the donating public and the professionals like you and the OPOs like Donor Connect that have really driven the growth in deceased organ donation for transplantation, and not the opioid epidemic. Okay, but what else are we seeing in terms of trends that have driven the growth? Well, we've seen a really large increase in DCD. Does everyone here know what DCD is? I'm seeing some nodding heads and some maybe not. Okay, so DCD is donation after circulatory death donors. So typically organ donation happens when a patient dies and is declared based on neurologic criteria, brain death. But there's also opportunity in circumstance where a patient has a non-survivable brain injury, is not going to meet brain criteria, but there's a decision to withdraw the ventilator, and there'll be a recovery of organs after death has been declared. Ventilator withdrawn, asystole, death is declared, and then there'll be a recovery of organs. And this has been a major increase and growth in the US over the past 10 years. Huge, 388% increase. And this was predicted in the data, that this was a pool of potential organ donors that had been largely untapped, so to speak, in the US as compared to European countries where they were doing a better job utilizing organs from these potential donors. And so you can see, especially since basically 2018 on, a very steep increase in DCD donation. So just to be clear, in DCD donation, the patient will be, is not declared until right before the recovery of the organs. So the clinical process is different, right? So question for you. And we don't have polling technology for you here today, so I'm just going to, can you imagine after all that? so we're just raise of hands here. Legal authorization for DCD is different than when the patient is brain dead because the OPO is working with the family before the donor has died. Legal authorization for DCD is different because the family needs to give informed consent. Legal authorization is the same for DCD as is for brain death. Legal authorization is the same unless it's a registered donor, then it's different for DCD. So how many for the first one? It's different because the OPO is working with the family before the donor has died. Different because the family needs to give informed consent. Same for DCD as it is for brain death. Same unless it's a registered donor, then it's different for DCD. Everyone's afraid to maybe raise their hand. Yeah. So it's the third one down. It's the same. It's the same. So the UAGA governs donation after death. And that's regardless of how death is declared. Okay? And donor registration authorizes donation after death, regardless of how death is declared. So it doesn't matter under the statute whether death is declared based on neurologic criteria or based on circulatory criteria. Either way. So authorizing donation does not also authorize withdrawal of support, so that's a really important point. So with DCD, you have the component of withdrawing the ventilator. That's not part of authorizing organ donation. That's a separate process. So that requires surrogate consent. That's an informed consent process. And we know that withdrawal has to be done in a way that will allow DCD to proceed. So the law kind of sees these as two separate things. There's the withdrawal, and then there's the organ donation. But one important thing to point out from an ethics perspective is the timing of the discussion. And because sometimes I do get people who, in the earlier slides say, well, the patient has not yet died at the point where the OPO is discussing organ donation. So it's completely different. And it's not completely different, but it's important to address that. The dead donor rule, which maybe some of you have heard of, it's an ethical principle, it's a rule. I'd like to say as a lawyer, it's also kind of, a homicide statute, which is that the recovery of organs can't cause the death of the patient, right? That's a really important ethical principle. That doesn't preclude discussing or obtaining consent, that should say authorization, right? To donation prior to death, right? The dead donor rule is about recovering the organs in a way that to make sure that the recovery of organs doesn't cause the death. So separating out the withdrawal decision from the donation decision is really what the dead donor rule is about. Many years ago, the Institute of Medicine had a report about this, and it used the word decoupling to say that the decision to withdraw needs to be made independent of and prior to the donation discussion. But the prior to was in the context at that time of, a system where we didn't have robust donor registries. And so it was at that moment in time, always the case pretty much, that you were doing withdrawal and then approaching surrogates for permission. And that's really no longer the case because we have half the time patients that have registered and made the decision for themselves. So in fact, the decision to donate has been made well in advance of, prior to the decision to withdraw that's being made by the surrogate at the moment. The ethical firewall was really important under the IOM, but that can be maintained. And again, this was really in the context of surrogate decision for both. So donor registration in DCD really effectively decouples the donation decision from the withdrawal decision. I mean, the decision for organ donation may have been made months, years, maybe even decades prior to this withdrawal decision that's being made. So different time in advance of the withdrawal decision. And it's a separate surrogate consent for the withdrawal and any premortem procedures that need to take place. So I think that the ethical principles that the Institute of Medicine laid out decades ago for this really do still apply and are adhered to in these circumstances. So I think a lot of this is about hardwiring donor registration in DCD, making sure that both the OPO and the hospital are on the same page, understand the law. And I think the frameworks are really helpful for this because it sets out why it's different than an informed consent process, why the donor registration matters, why it's incumbent upon all of us to make sure that we're following an individual's decision that's been made, why the law sees that as central, what the ethical underpinnings of this are, that we have confidence in those ethical underpinnings as part of an autonomy right, and that we respect that. And then address the timing components. So the timing components are really important, and I want to show you an example from our OPO. This data is now a number of years old, but I think it's pretty striking. So we saw that we were asking families when authorization was not obtained what their reason for saying no was. And we found, this was in DCD circumstances, and we found that the timing was the biggest reason. This is a cohort of data from 2018 through 2020, that they didn't want to wait. They had made the decision to withdraw and they weren't wanting to wait. And so we set about a quality process to pilot how we might address the timing issue and do a little bit better for our families. And so what we did was we implemented what we called preliminary discussions, which was backing up that discussion about organ donation much earlier in the process. Instead of waiting until families had made the final decision about withdrawal and were ready to go and be done, introducing the conversation about organ donation earlier, even if it wasn't the full authorization process, or introducing the fact that the individual had registered as a donor, if that was the case, which was about half the time. And you can see here that the authorization rate was substantially higher when we did a preliminary discussion. Really encouraging results. So as soon as we saw that, we implemented this strategy widely, right? And rapidly, and we saw a major improvement in just the first 10 weeks. We were able to drop that down. And you won't be surprised to hear that now in 2024, this is a standard part of our practice, that our goal is to, in the majority of cases, have preliminary discussion. And our OPO, we have about 50% of our cases are DCD. And we are a large OPO. We are on pace to recover over 600 organ donors this year. So this is a standard part of our practice now. Okay, so switching gears a little bit, Sometimes family members disagree with decisions that individuals make. Now, of course, this is within living donation, but the question does come up frequently: can family revoke a donor designation at the time of the patient's death? Hands for true, hands for false. Right. So it's false. And so I think, it's important to say that it's false. And there have been cases, this is one out of our area in Boston, but they're rare because nobody wants to go to court. This is not what we do. This is not our work. Our work isn't to be running to court. Our work is to support families and make organ donation happen for life-saving transplants for patients. So what happens when families object? Generally, we think about potential benefits of moving forward, and again, respecting the autonomy rights of the donor, maximizing the potential good. And this is really important, assessing the lives that can be saved through that donation, that there's a shared accountability for donation. And from a policy perspective, I think that's really important to keep in mind. So our country has an opt-in system, but that's a shared responsibility. So we're asking people to opt in, and then it's our responsibility as medical professionals then to take that opt-in and make it happen when there's actually an opportunity to make it happen. Of course, as a lawyer, I like to point out it's important to comply with the law. There is potential positive media in following an individual's decision. Also recognize that there's potential harms of moving forward, which can be potential negative media. So media can be on both sides of this. And we've seen that play out. And family distress is something that, of course, we're concerned about because, again, we're not in the business to cause distress. So how do we support families, reduce this conflict, and continue moving forward, which is what we do. Even when there is this kind of conflict, we engage ethics committees. We make sure that leadership, both at the OPO and the hospital level, are engaged. We engage legal. This is really important. I'm going to get back to this in a moment. Definitely engage public relations and make sure everyone's ready for this if it happens, which should be very rare, because reducing the legal conflict is actually, in many ways, the simplest part. There are clear legal standards here. This generally isn't a legal issue. It's not a legal issue. The law is quite clear. The policies at the hospital and the OPO should align with the law, and there should be consistent communication about that so there isn't confusion over we might have a legal issue. It's not a legal issue. It doesn't mean that there isn't an issue or that it isn't complicated or difficult to deal with, but it isn't actually a legal one. So knowledge of the law and ethics is important, but ultimately what this really is understanding what the escalation protocol is that's in place. What's the basis of the family objection? Was there a mistake or an error in the registration? That could happen. There was a case out of New York like that, so you want to confirm that there's been no error. Were there contrary statements made? But again, verbal, not going to count. So you got to find something in writing. Understanding the basis of objection and having that good communication. I mean, you all know that handling family conflict is understanding at its core really what is the problem. Assessing transplant potential is also really important, taking that step back and saying, we're doing this for a reason, which is to save lives. And so we do want to make sure that that suitability is there when we know we've got a real conflict going on, so that we're not doing all of this and causing any kind of distress without the potential benefit that is the reason why we're doing it. All right, so what if you do all that and they say, we're calling our lawyer. And so what I like to say is I absolutely support donor families seeking legal advice because a lawyer looking at this is going to see that the law is clear and can actually be very helpful in de-escalating a family situation. So I always encourage donor families to seek counsel if they're interested in that or they feel that they need that. Absolutely positive to helping clarify the situation. Engaging counsel everywhere is generally good. I mean, I know doctors don't love lawyers, but this is a circumstance where it can help actually bring everything down a level. And we've already talked about kind of the clear documentation, getting the document of gift, so to speak, whether that's the registration from the RMV or wherever it might be. Sometimes it's in an advance directive, and actually showing the families that signature, that can really help too. The law is clear and it has your back. This is my favorite slide ever because lawyers never get to say this, right? Have you ever heard a lawyer say that? But it's true. And so how does it have your back? Well, a couple ways. So first of all, the law, the Uniform Anatomical Gift Act, says that the rights of the person to which the part passes, and part is the term that it uses for any organ or tissue that's being donated, is paramount. It's superior to all others. So meaning that the obligation to coordinate this donation is given importance and is primary under the law. And then there's also good faith immunity from liability, that those who are acting in reliance on the law, including presuming that the donor registration is valid, are immune from liability. And it's a complete legal defense unless there's any question of fact. So this is a very strong policy choice that legislators have made in every state. This provision exists in every state in the country to really discourage lawsuits and to make sure that organ donation in our opt-in system can function as well as possible. Okay, so what happens if you actually end up in court? I'm not going to spend much time on this because honestly, it's extremely rare. Occasionally you can, as I showed you, there was a case that we've had we've had two, I think, in the past maybe 10 years. Emergency hearings can happen. The legal standard that's used in these hearings is balance of harm, likelihood of success on the merits, and public policy. So, I mean, I've already talked about the balance of harms. They weigh in favor of moving forward. The likelihood of success on the merits, the law is pretty clear, unless there's some defect in the document of gift. And the public policy of saving lives is also pretty clear. So we had a case. Again, in the interest of time, I think I'm not going to go into a lot of detail here, but it was pretty dramatic. We had a 42-year-old, it was a brain dead donor in Massachusetts, but registered in Virginia. So this is where that uniformity in the law is really helpful. So there's this full faith and credit amongst registrations, and you probably get that here too. You have people who are coming into this area for vacation or whatever it might be. Maybe they've registered somewhere else. It's going to be recognized here. The family objected. They didn't tell the care team and they just ran to court. This is super unusual. We were actually in the OR. We had a thoracic team in the OR and someone came running in with a court order. This is like out of Grey's Anatomy, right? And then they called our legal team and me, and we had to sort of halt the organ recovery and resolve this, which we did. There was a virtual hearing immediately. This was, of course, on a weekend, right? Yeah, it was a Saturday, like in the middle of July. And testimony was presented. And, you know, the outcome was the recovery moved forward. And I have to say that, you know, the two times that we've had this materialize, both times the families have ultimately accepted the result. And, you know, it's really an interesting thing. I don't know if, like, they needed this step. I can't explain that. But, you know, obviously there was substantial conflict for them to feel that they needed to go to court. And yet, at the end of the day, both times the families not only accepted the result, we had an honor walk at their request for one of them. And in both instances, they wanted follow-up to hear what the outcome was, wanted to, you know, connect with the recipients. No negative media in either case. In fact, no media at all in either case. And in this one, 4 organs were transplanted, including the heart that the team had been like there and waiting. Switching gears a little bit, I want to talk about one other important part of the legal structure that makes our whole crazy system work. So this is an awesome graphic of the transplant system that the SRTR, which is part of HHS, has a contract with. They do the registry of outcomes for transplant patients, and they've done this kind of subway map of patient's experience, which is the blue line and all the different pieces. And the donor hospital is in orange. The OPO is in sort of the reddish color. And you can see there's so many stops along the way. All of these things have to come together to make life-saving transplant work. And so these policies and frameworks and laws that are put in place are really designed to make sure that this happens, because it is really complex and it requires structures to make it successful. Just recently in 2022, the National Academy of Science put out a report about realizing the full promise of organ transplant. And one of the recommendations specifically focused on donor hospitals and looking at the highest performing donor hospitals as a way to maximize the whole system. Now, I mentioned before that only about 2% of inpatient deaths have the medical opportunity for organ donation. So when you think about that, 170 million registered donors, and then you know that there's patients waiting and patients who die waiting. There's about 104,000 patients waiting in the US for transplant. That's where that gap is, that there's actually, a limited pool of potential donors. And so we know that our opportunities kind of at bat are really small. And that's why each one is incredibly important. And that's why all of these policies are lined up to try and make sure that when we have those opportunities, especially when someone has taken the time to opt in to our system, that we're honoring that. Okay, so sometimes what I have here is this idea of a clinical conflict of interest. And what I'm getting at is what the law and the regulations set up is that when there is a potential organ donor, that they must be maintained so that the OPO and that opportunity for organ donation can be assessed, the registry can be checked before anything else is done, so that that opportunity isn't lost. And the question sometimes comes up like, well, is there any clinical conflict of interest in doing that? And I like to point out that a conflict of interest is when there's two competing interests, where the possibility of benefiting one can influence the course of action leading to a potential harm to the other interest. And so generally we think of continued critical care provided to patients serves multiple interests. The patient, the patient's family, potential recipients, if organ donation might be an opportunity in society. So there are two interests here, thinking from the organ donation perspective, the patient and potential recipients, but that they're not actually in conflict, they're in concert. And that's the way we look at it. That's the way the federal regulations look at it as well. So a lot of text here, but essentially requiring hospitals to make sure that they report all deaths to the OPO. That's that first step to make sure that we're capturing those opportunities, that the OPO then is screening every single one to identify and then send staff and make sure that the best approach is happening. And then also, as I mentioned, maintaining potential donors so that we're not losing opportunities before they happen. CMS has interpreted this also to, again, make sure that we're lining everything up. And the UAGA itself, the statute, also has a similar provision in it that during this examination period where OPOs are assessing that opportunity, that all measures necessary to ensure the suitability are maintained, that they can't be withdrawn. So essentially making sure that ventilators aren't withdrawn while that opportunity for organ donation is being assessed. So it's really amazing when you think about it, though, that we've got federal regulations, state statute, interpretive guidelines for hospitals, and all of these standards lined up to make sure that in real time this happens. And it takes the collaboration of all of our teams to make this a reality on the ground in the front lines on a daily basis. So I think, kind of to wrap this up, the legal standards support these ethical practices, the precision of when death occurs, how it's declared, transparency to how we do our work, why gift law is the framework, helps preserve the public trust, which is how we have the donating public continue to grow organ donation and transplantation. And with that, we really shine. The US has outperformed pretty much every country in the world other than Spain, although I have to say that in 21 we outperformed Spain. So it's kind of a contest between US and Spain. We don't have the 23 data yet because the European countries are a little behind on their reporting, so we should get that soon. But you can see a big gap between our two countries and basically everyone else. So I think we should be really proud of what we do. And this is my last slide. This is the hallway of our OPO in Boston. We like to say we're impatient optimists, which is that we're impatient for a future where every patient who's in need of an organ transplant has one available. And we're optimistic that we're going to get there. And that optimism is founded on hope, in part, but it's also founded on really hard work and collaboration and the results that we're seeing and the performance of our system nationwide and locally for us, and certainly here as well. You have an incredible OPO that's doing great work and is growing organ donation and transplantation with the collaboration of teams like yours. So with that, I'm going to stop and I'd be happy to take any questions. So first of all, I guess I would respectfully disagree that there's not information out there. I would agree that it's incumbent upon the individual to decide how much information they feel they want or need to make this decision. The information's available online in many, many different places. It's available, Donate Life America. It should be available through your RMV online. I haven't looked at Utah's, but I'm getting nodding faces here. It should be available on your OPO's website. I know it is because I've seen it on your OPO's website. And if you even just Google, organ donation, you will come up with lots of information about it. But again, it's not an informed consent process. So, adults are making impactful decisions for themselves all the time where we're not testing whether or not they understand everything they're signing. Mortgages, I could give 100 examples. So it's like, I certainly would disagree that it's not in our interest. I think we want people to make this decision because we think it's a good and right decision to make. And because surveys, Gallup poll, for example, show over 90% of the US public support organ donation. And people want an organ available if they're in need of a transplant. And if you're willing to accept a transplant and you want one available for you or your loved one, then you should be willing to give. And what we find generally is that people aren't interested in the details. This is just my own experience, that they want to be organ donors and that's enough. There are some people who want a lot of information and it should be available to people who want the information. And I don't know if there's other points that, the Donor Connect team want to make about that, but I think, again, it's not designed to be an informed consent. We want the information available, but ultimately it's opting into a registration.